Good morning, everybody. It's so nice to see everyone. Welcome. I'm Saray Parangi, and we welcome you to this wonderful meeting in Lexington, our 46th meeting. We're going to start out by showing a very short clip by Sonic Healthcare, one of our wonderful industry sponsors. As you know, we've been making a lot of partnerships with industry, and these partnerships are very important to our organization and our ability to bring new technologies to you. And we're hoping to make stronger and stronger connections with industry for our members so that we can get involved with additional funding, research, et cetera. So please welcome this lovely video welcome from Sonic Healthcare. Hopefully soon. Okay, welcome and thank you for being here. I'm going to go through a couple of introductions and making sure that we really thank everyone who's put an amazing effort into making this meeting possible. So we'll start with the introduction of the AAES officers. So Paul Gager is the president-elect, Dr. Carrie Cunningham, our secretary, who's been working tirelessly, Jim Howe, our vice president, Rachel Keltz, our recorder, and of course Lin-Hua Yip, our treasurer, who's done a wonderful job. So thank you for everything that you've done to bring us to this day. And then of course a big thanks to all of our counselors and past presidents on the council. We had a wonderful meeting yesterday, moved a lot of agenda items forward, and I think you'll hear about many of those initiatives during this year. So thanks Becky, Carmen, Cord for being past presidents and yet giving of your time. And to David Velasquez Hernandez, Joyce Shin, Dave Schneider, Scott Wilhelm, Masha Livitz, and Ben James, who couldn't be here because he just had a baby, or his wife, I guess, technically just had a baby, a little girl. And then we couldn't do anything that we do without the AMR staff. Our management company have really been amazing partners to us. And Lauren Santangelo, the executive director, helps us run a tight ship. And Gina Cairo joined us this year as program manager. Hillary Wicks has helped with securing the site and making sure every little piece of the puzzle fits into place, from food to location to rooms to posters. And then Zoe has been helping with the membership coordination. So thank you. Let's give them a big round of applause. And of course, I couldn't live without Abby Fingerett, our program chair. I was so grateful. That was when I got chosen as program president-elect. They said, your first role is to find a good program chair. And I asked, and Abby said yes, even though I know she's extremely busy. And she was actually, at that time, also getting a PhD, just a little minor thing. And so I'm really grateful, Abby, that you helped design this program and really made a lot of changes, which I think you will see in the program as it develops, with a lot of innovative ways of making sure we heard your voices and brought in programs that you wanted to see. And a big thanks to the entire program committee. They worked so hard on all the different components, from which rooms, which boards, which tumor boards, et cetera, and you'll see the results of that. So a big thank you to the program committee. And really, we couldn't do that if we weren't here in this beautiful city and with our University of Kentucky College of Medicine colleagues. Courtney, you've been amazing. Thank you so much for everything you've done to make this happen, to Barry and Abnett. And now I'd like to introduce Barry to come up here for a minute to just thank you and the team. If you guys could come up, it would be great.
Welcome, everybody. We are so excited that you're in Lexington. Thank you for being here today. I want to give a big shout out to my senior partner, Dr. David Sloan. Without his vision for a section of endocrine surgery at UK over 20 years ago, none of us would be here today. So thank you. I had the pleasure of joining him about 15 years ago. Reese Randall, who's now at Wake Forest, joined us. We were able to recruit an amazing chair who also happens to be an endocrine surgeon. About 7 years ago, Dr. Fackelmeyer joined us 5 years ago, and now Dr. Kelly Stahl. So we are very excited to have our fellow soapboxers in the city with us. I know a lot of you have already enjoyed some of our horses and some of the bourbon. If you're just like, dang, I've missed all of that, come to the gala tomorrow night. It's going to be all kinds of Kentucky, and we're really excited to have you there. So thank you all for being here and enjoying our city. And if you have anything that we can help you with, please just reach out to us. Welcome.
I'd like to allow Dr. Barry and Abnett to give us some additional welcoming remarks, and he will introduce Dr. Bob DiPaolo as well from University of Kentucky.
Good morning, everybody, and welcome to Lexington. It's such an honor to have you all here, and this has been 5 or 6 years of planning coming to fruition. We hope you enjoy our beautiful city and our state. It's my great pleasure to introduce Dr. Bob DiPaolo, who is the provost of the University of Kentucky and co-executive vice president for health affairs. Prior to that, Dr. DiPaolo served as the dean of the College of Medicine and vice president of clinical and academic affairs for UK Healthcare. Dr. DiPaolo is a first-generation college graduate and completed his medical degree from the University of Utah, and then went on to Duke University for a residency in internal medicine, followed by a fellowship in hematology oncology at the University of Pennsylvania. Prior to coming to Lexington, he served as the director of the Rutgers, NCI Designated Comprehensive Cancer Center, a position currently held by AAES past president Steve Labuti. He's published over 200 publications in prestigious journals such as New England Journal of Medicine, The Lancet, and JAMA. As co-EVPHA, he has worked tirelessly on many initiatives along with the UK Healthcare leadership team, including a refresh of our strategic plan, the launch of a service line structure to better serve our patients, as well as enhanced programs and approvals for new facilities to enhance access to serve the health and healthcare needs of our Commonwealth. So please join me in welcoming Dr. Bob DiPaolo to the podium.
He forgot the most important thing. It was my opportunity to be in part to recruit Dr. Abnett to be chair of surgery, which has just been incredible. Anyway, good morning, all of you, and thank you for joining us here in Lexington for the American Association of Endocrine Surgeons annual conference. Hopefully you've gotten a bit of feel for Lexington. I know we talk about it being bourbon, horses, basketball, but I think you could see it's much more than that. And it's an honor. It's an honor to be in the midst of such prestigious and talented people, all of you. Dr. Abnett mentioned, I'm Bob DiPaolo, I'm the Provost and Co-Executive Vice President for Health Affairs. I've actually had the privilege of serving here at the University of Kentucky. It's now 10 years this month. As a land-grant institution, many of you may have seen some of the campus, and you may not have, but if you have an opportunity, it's a fairly comprehensive campus. We're a land-grant institution that's committed to serving the entire Commonwealth. And our work is framed in a similar way to your association as a whole, as I can see the agenda, integrating research, integrating education with clinical care. And at UK and UK Healthcare, we often define our work by 3 strategic pillars. First, enhancing advanced subspecialty care, so no patient necessarily needs to leave the state for any advanced care. Taking care of our people and our partners, as UK Healthcare is a hub for the state, but we can't do it without our partners and networks throughout the state. And the third distinction, and most importantly, as an academic health system, as is the theme throughout this conference, integrating research and education with clinical care. Given these pillars, it's impressive to see what you're doing around the country and beyond the country, and meeting some of you here this morning. And certainly the meeting sessions in this annual conference with areas that just include so many different things and areas based on science, including utilizing AI, integrating multimodal AI imaging, advanced robotics, genomic-driven precision medicine, and haptic feedback technology, just to name a few, and there's a lot more. Our UK healthcare system has also been growing. We are now 6 hospitals total around and throughout the state, totaling 1,700 beds and more than 72,000 discharges annually. As an academic health system, we are integrated with the College of Medicine and 6 other healthcare-related colleges. In fact, our chair of surgery, Dr. Nabnit, also holds the title of Surgeon-in-Chief for UK Healthcare, in addition to his chair role in the College of Medicine. The team, many of whom you've met in the Department of Surgery, are a testament to the work happening across UK Healthcare and the College of Medicine. And in fact, in the past 6 years, they've recruited more than 60 providers, grew further advanced subspecialty care, improved access, and provided exceptional educational opportunities for our learners. And they have secured research funding that contributed to the university's record high R&D spending this year. While the work is tremendous, it isn't finished, as we still need to increase capacity to serve more given the health disparities in Kentucky. And hopefully as you explore Lexington, if you have an opportunity to do a quick tour through the campus, it's going to be impossible to miss the growth and investment in infrastructure on our healthcare campus. In fact, we tend to tout, I don't know if it's a good thing, that there are 8 cranes actually at this point, which just represents growth. A few examples: recently the Markey Cancer Center achieved NCI designated comprehensive status in the past couple of years, and we are nearing completion of a new cancer and advanced ambulatory building to further meet the needs of the state. Additionally, site work is planned for a new tower of the hospital. It'll actually add about 900 beds. And finally, the new Michael D. Rankin, MD, Health Education Building is going to open the spring of 2027. And this building will co-locate 4 healthcare colleges and the Center for Interprofessional and Community Health Education, all of which will help us tackle the provider shortage we face, which is also severe in Kentucky. So to close out, I just wanted to share a quote by Michael DeBakey. He said, "The natural history of science is the study of the unknown. If you fear it, you're not going to study it and you're not going to make progress." We're all healers here, and I know that you're all not afraid to study the unknown and discover new techniques, procedures, and therapies, and engage new technologies. That's what we all do. And that's why you're here today and through the conference. I hope you enjoy the rest of the conference. And so on behalf of the University of, for, and with Kentucky, thank you once again for being here.
Okay, a big thank you to all of our sponsors. We have a large number of sponsors this year. Every year we pretty much sell out our sponsorships. So please make sure that you thank all of our sponsors, that you go to the exhibit hall and really pay attention to their products, their people, and know that they are here as partners to us in helping our patients and making sure that they get the best quality, safest care. So big thank you to all of our sponsors. I also want to specifically mention a new travel grant that we were able to obtain this year from Neurovision. On behalf of the AAES, I'm pleased to announce that we have a long-term partnership with Neurovision Medical Products. Neurovision is deeply committed to understanding and supporting the important research of our members in thyroid and parathyroid disease. Through this partnership, Neurovision has agreed to provide annual travel grants to support our early career members in attending the AAES annual meeting and presenting their work. This year, we're proud to award the Neurovision travel grant to 15 of our trainees for $1,000 each. And we're very grateful for the commitment that Neurovision has made to advancing surgical education in this way through this partnership. So please join me in thanking Neurovision for their generous support. I would love to see all the past presidents please stand up. Peter Angelos, Herb Chen, the ones who are here, please stand up. Jerry Doherty, Quan Du, Doug Evans, Janice Pasica, Ashok Shaha, Alan Sipperstein, Rebecca Sippo, Tom Fahey, Miguel Herrera, Chris McHenry, Carmen Solorzano, Cord Sturgeon, and Martha Zeiger. Please stand. Oh, and Jack Monchak. Please stand up. Thank you for being with us, and thank you for continuing to support the organization. I know there was a wonderful past president's dinner by the foundation, and it shows how connected you all remain to the organization. I'd love for Dr. Solorzano to come up now to help recognize the Solorzano Travel Award recipients. Yeah, go ahead, come up though. So as we know, Dr. Solorzano has generously helped support this new award to increase the partnership with many of our colleagues who have trouble coming to this meeting because of the cost and the time commitment. So we'd love to first start with the first awardee, Dr. Sofia Anaya Sanchez from Instituto Nacional de Ciencias Médicas y Nutrición from El Salvador. Oh, sorry, I don't know why I said that, from Mexico City. Please come up and receive your award. Yeah, just stay up here for a minute. I'd also love Dr. Alicia Mercedes Lopez Garcia, coming from the Ministry of Health of Nicaragua and doing an observership at the University of Alabama and Vanderbilt. Please come up. Congratulations. I just want to announce, sorry. We also have, in addition, Dr. Alvaro Sanabria from Colombia, who's been selected to do an observation, but is not here today. So I just wanted to acknowledge her as well. Thank you. Thanks a lot. I also just want to highlight that we have a very special guest as our keynote speaker, Dr. Daniel Hashimoto. He will be our UCSF Carolyn Orlo Clark Distinguished Lecturer in Endocrine Surgery. That will be today at 2 p.m., and I can promise you it'll be an amazing lecture, so make sure you don't miss that. We also have our own Dr. Wen Shen, who is going to be the Medical College of Wisconsin Stuart Wilson Historic Lecture. Again, this will be tomorrow at 10:30, not to be missed. I promise you, you will learn more about Oliver Cope, our highest award here in the organization, and you will be impressed. I do want to highlight a couple of things that are a little bit different maybe this year. One is the digital posters. So we don't have paper posters anymore. We've moved on. So you'll notice that we have 4 screens in the exhibit hall in the foyer area. Please go to the poster boards, interact with them. It won't be the same as before because it won't be on paper, but I promise you it's actually been really effective. We just saw the poster presentations upstairs and they were fabulous. We also have a video monitor in the foyer with video of several AAES legends through the Icons in Surgery program. Again, we think not everyone knows about our icons, and so it'll be a really good program. If you have a little time, you're eating something, drinking something, take a break and use those. And of course, we have the amazing breakout and panel sessions. Sunday night will be gala celebration, a night at the races with the theme of the meeting. I'm going to invite Carrie to come up.
Carrie Cunningham, AAES Secretary. I'm here to discuss a little bit about a couple of our colleagues and our beloved benefactor, starting with Goran Ackerström, Carol Clark, and Benson. It would be remiss of me to not discuss mental health awareness at this opportunity. So I'd like to make a few comments. As physicians, we are proud to take the Hippocratic Oath on our medical school graduation day. We are bestowed a tremendous privilege and honor to care for people in their time of need. We also take on tremendous responsibility, and we always put our patients first. Physician depression, substance use disorders, and death by suicide are significantly higher in the general population and even higher in the surgeon population. Our struggles are coupled with the fear of losing our career and reputation. Doctors avoid seeking treatment for fear of being found out, and this isolation exacerbates the illness. We have come to define success with not needing anyone. Not sharing any emotion is equated with strength. Mental health stigma and overt and unconscious bias of people with mental health disease are rampant. But we can affect change. We must make it safe for physicians, trainees, and students to seek help. Contrary to commonly held beliefs, exposure to suicide content reduces suicidal thoughts and behavior. We must talk about it. Check in with those who you believe are struggling. And like today, we need to honor and learn from the tragic loss of our loved ones and colleagues. In this vein, the green lapel that you'll see many of us wearing and are available at the registration desk are in support of mental health. It's actually an international pin. And in honor of Benson and the many others who are suffering silently. Please take a moment of reflection for all of those we have lost this year. Thank you. There are some tributes and contributions, the contributions that each of these individuals have made in the AAES book, and I appreciate you listening to me. I'd like to invite next Herb Chen from the AAES Foundation for him to discuss their incredible work this year.
Morning, everyone. So I'm being joined up here by Doug and Tracy, who are the secretary and treasurers of the foundation, as well as Lauren, who did all or most of the work to develop this incredible auction. And I'm going to have her come up and just tell you a little bit about how to access it and also about the live event. And can we get our slides?
While they're pulling those up, I'll just say I'm very excited about the auction this year to support the foundation. Do I have to push this? Okay.
Oh, there we go.
The first part is going to be our virtual auction. I've just been blown away by the generosity of our members. There's so many great items. This is just a few of them, but there are experiences, tickets, other ticket items. There's food, wine, and there are a lot of experiences that you can have at next year's meeting, and you can bid on those events with really wonderful members of our community. So we're very excited about this. And that will end during the gala. And then we will also have our live auction during the gala. There are 3 items that are listed here. I will note they are listed on the virtual website, which you can access through that QR code or through our app. We put the starting bid at $100,000 just so you won't bid on them. So it's not available at $100,000, we promise. Unless somebody wants to, and then that's okay. But we're very excited. So there are 2 vacation trips, and then there's going to be a Napa wine tour. We're so excited about this. 3 presidents in each team, and they're going to face head-to-head to get the highest bid tomorrow. So come prepared to join one of those teams, and we're really looking forward to having these 2 experiences. Thanks.
Janice isn't competitive at all right? No, I thank you, Lauren, for all this, and we look forward to tomorrow at the gala. We'll want a lot of engagement at this live auction. And I'm just going to stop back. So if you didn't get a chance to get the QR code on your phone for the auction, I'll just leave this up for a second here. And it's live right now, and we'll go through tomorrow just at the end of the gala. So please participate. I've already bid on a couple things myself. Okay. And then we just wanted to really thank our members who have made contributions to the foundation. Your donation is so important to the vital work that the organization does, from supporting the meeting itself, supporting travel awards, and we have a lot of exciting things coming up, and so I want to recognize the donors at the founders level, the gold level, the 1979 level, our Thompson Fellows, all listed here, as well as our rhinos. And these names are also listed in the program book. And I would invite you, for those, first of all, thanks for those of you who have contributed. And if you want to move a level up, please let me know or approach me, Tracy or Doug, and we'd be happy to make that possible for you. And those of you who want to join anywhere on this donor roll can also approach us as well. Thanks so much.
We're doing great up here. Lauren, can you put the ultrasound US back up, please? We just wanted to acknowledge all of the incredible work that Barb Miller and everyone who, and Courtney and others, and everyone who contributed to the ultrasound courses and to the ESU. They were fabulous. I stopped into each of those as well. So we just want to acknowledge them as well. One note about, another off script, Lauren loves this, a note about the app where we're getting a lot of questions. So if you download the regular AAES app, on the bottom right, there's, you can click on, I think there are 3 dots, and there's a section there to go to other events, and that's how you get to the meeting portion of the app. Another note about the self-nomination process, you should have received an email a couple of days ago now, I believe. The QR code will be on the screen, and they are open. Please, we would love to get people. There's so many people who are super committed and want to be more involved in the AAES. And on that sheet, on that website, you can see, do you qualify for this certain, there are trainees, there are candidate members and full members, et cetera, on there. So please, we like as much engagement as possible. Please make sure you stop by our exhibitors. They've been really important to us putting on such a great program. There will be multiple live product theater presentations during some of the breaks, and we'll be announcing those as we go along. For fun, Abby Fingerette and the DEI committee have put in a few games this year at the registration desk. There are a couple of bingo cards, one for trainees and one for attendings. And so those will be a chance to win a bunch of raffle prizes and swag that you'll see out tintillatingly out on a table out there. And in the DEI committee, for anyone who does the New York Times Connections puzzle, Nancy Cho and the DEI committee came up with a Connections game for us to play. So please check that out. Next, I would like to invite Joyce Shin up, who is our membership chair, to introduce our new members.
Thank you, Carrie. It is an honor to introduce this year's new members of the AAES. When your name is called, please come up on the stage and just stay up here so that we could take a picture at the end. And please hold your applause for the end as well. John Abikhaled, Miriam Ali Mucheru, Serena Baines, Talia Barnikas, Alexander Chu, Jessica Dolly, Stephanie Davis, Tatiana Fedorova, Patrick Hangy, Yinin Hu, Bernice Wang, Amna Kokar, Lauren Krumek, Francis Lee, Jason Liu, Jessica McMullen, Sarah Mitchell, Michelle Mulder, Salem Nuraldeen, Rafael Perez Soto, Ala Sada, Vivek Sant, Yuja Shah, Mohammed Sidani, Sarah Sims, Lee Stratton, Samuel Zubar, and Mehmet Kostek.
Okay, now we can clap.
Big smiles.
Thank you.
All right, I would like to invite Heather Watchell to the stage to introduce our Research Award speakers.
Thank you so much. As the chair of the research committee, it's my distinct honor and privilege to have the opportunity to introduce some of the fantastic work that is being done scientifically by many of our members. First, we're going to have 3 presentations from our 2024 Research Award recipients. The Paul Lugerfo Research Awards are very generously funded by the AAES Foundation each year. And through our very generous partnership with THICA, they financially support the Thyroid Cancer Survivors Association Award for thyroid cancer research. So if you'll join me in welcoming Dr. Lauren Crummock back to the stage. She, from the University of Michigan, she was the 2024 Lugerfo Award recipient, and she'll be sharing some of her work with us today. I'd ask you just to hold any questions to the end of the session, and you can approach the presenters individually. Thank you.
Thank you so much. That's dangerous. Well, with my pregnancy rhinitis, I need something. All right, do I have to move forward or?
You'll have to pull our slides.
Okay. Thank you, and good morning, everyone. I have no relevant disclosures, but have listed my funding here. I first want to take a moment to express my gratitude. This award not only supported our research financially, but also gave me the opportunity to share our work with others and enhance new collaborations that have further propelled our work. You'll also notice that I was quite pregnant upon receiving this award and find myself again pregnant today. So it has been challenging but rewarding to be growing my lab and my family simultaneously. The shortness of breath prevails. Our lab is passionate about studying immune privilege in adrenal metastases so that we can further organ-targeted cancer therapy. Adrenal metastases are prevalent in a number of malignancies, as you can see here. Lung cancer is the #1 cause of cancer-related death in the United States, and as shown here in autopsy studies, the rate of adrenal metastases is upwards of 36%. So we were motivated to use lung cancer as our primary model to study adrenal mets, recognizing that this work may be relevant for other cancers as well and further the impact of our work. Importantly, patients with adrenal metastases seem to do worse than others with metastatic disease. Shown here is our recent study looking at patients with stage 4 non-small cell lung cancer at the University of Michigan who were treated with immune checkpoint inhibition. And you can see a worse overall survival among those with adrenal metastases, which underscores to us a unique adverse biology in the adrenal gland. The adrenal is a remarkable organ that has distinct functional layers, and the zona fasciculata produces glucocorticoids. It's estimated that the adrenal cells are exposed to up to 1,000-fold concentration compared to systemic levels. Glucocorticoids are known immunosuppressants that impact multiple immune lineages. So this sets up an environment for potentially locally immunosuppressive area where metastases can thrive. Consistent with this biology, we've clinically witnessed asymmetric response to immune checkpoint inhibition. Shown here is a gentleman with squamous cell carcinoma treated with pembrolizumab, which works by augmenting the immune system, and you can see a partial response in the lung, but a blossoming adrenal metastasis. So as one of our grant aims for this award, we sought to characterize the organ-specific response to immune checkpoint inhibition and answer how often adrenal metastases are failing to respond. So we obtained records from 6,800 patients with non-small cell lung cancer at the University of Michigan, 600 treated with immune checkpoint inhibition. We excluded anyone who didn't have available imaging or had something that obscured accurate measurements, such as radiation therapy or a large pleural effusion. In all, we evaluated 54 adrenal metastases and 200 of the primary lung tumors, as well as any other metastases that were available. We evaluated the CT scan before and after immune checkpoint inhibition, and our radiologists characterized the organ-specific response to therapy as progressive disease, stable disease, partial response, or complete response in accordance with the RECIST criteria. Shown here is the organ-specific response to immune checkpoint inhibition. You'll see at the bottom, the rate of progressive disease of adrenal metastases was 63%, twice that of the primary lung tumor. We're showing the results of the unpaired data, so just all tumors among all patients, but when we looked in a paired fashion, the results were similar, so when we looked at patients who had multiple sites of measurable disease. We do note some limitations in power due to low sample size for some of the sites, but we noticed that the only other site that was statistically significantly different than the lung was the liver, which is actually known to be an immunosuppressive site in its own right through a non-glucocorticoid dependent mechanism. So this to us supports that adrenal metastases are more resistant to immune checkpoint inhibition, as we had hypothesized, and that this is likely due to an underlying immunosuppression in that area. So to further study this mechanism, we developed an orthotopic model. We inject non-small cell lung cancer cells into syngeneic B6 mice, into the left lung and left adrenal, shown here with a KRAS G12D model, which is a common oncogenic driver in non-small cell lung cancer. And you can see they grow single tumors in comparison to the contralateral normal organ. And shown here is with a KRAS G12C cell line, which is another primary oncogenic driver in non-small cell lung cancer. The rest of the data today are from this cell line. By H&E, you see a single tumor. It's infiltrating the lung parenchyma here. And similarly, on the left in the adrenal gland, you see that tumor that's infiltrating. And on the right, I'm showing staining for SF1, which is a transcription factor of normal adrenal cortical cells. So we wanted to show that there's residual normal adrenal in this model, which would support normal glucocorticoid signaling in this area. We then compared the immune infiltrate and the tumor-bearing organs by flow cytometry, and I'm showing the percentage as a rate relative to the parent population. In the adrenal gland, we saw fewer viable CD45 lymphocytes compared to the lung. The overall number of CD4 lymphocytes was similar, but the proportion that were immunosuppressive, FOXP3 positive regulatory T cells was higher in the adrenal gland, and there were relatively fewer CD8 T cells in the adrenal as well. The adrenal was also devoid of naive T cells, and although there were higher effector memory T cells, the central memory were similar between organs, and we noted a higher expression of PD-1 among the CD8 T cells, which can represent dysfunction and exhaustion and will be further studied by our team. But in all, this reflected a relatively immunosuppressive environment in the adrenal and was consistent with our hypotheses. To further the clinical relevance, we are developing the largest repository of primary tumors and their corresponding adrenal metastases from patients who've had surgical resection. These are FFPE specimens from our multi-institutional cohort. And thus far, we've performed multiplex immunohistochemistry with our collaborator among our first samples. This allows us to simultaneously stain for multiple immune markers and look at the organization of the infiltrate and their spatial relationships. And thus far, we have seen relative increase in the regulatory T cells in the adrenal gland compared to the lung, which was consistent with our murine findings and does support an immunosuppressive microenvironment in the adrenal. So in summary, adrenal metastases are prevalent, lethal, and resistant to immune checkpoint inhibition. Adrenal metastases are enhanced for regulatory T cells and PD-1 expression and deplete of naive T cells. And we're now going to be manipulating these pathways and cells so we can further get at the mechanism. I'd like to thank you for your attention and for this tremendous privilege. Thank you.
Thank you for that incredible presentation. I would like to next welcome to the podium Dr. Vivek Sant from the University of Texas Southwestern Medical Center. And as he's coming up, if we can pull up his slides, please. And Dr. Sant was also a recipient of the 2024 Logorfo Award.
Well, while I'm waiting for the slides, I just wanted to thank the entire AAES from the bottom of my heart. This grant has meant a lot to me, and at the very end, I'll just tell you about how much it has helped me in my professional growth and development. So thank you all so much. Allow me to set the stage here. In patients with primary hyperparathyroidism, we all understand that parathyroidectomy is the only thing that offers the possibility of durable cure. And despite that, only 25% of patients, even those meeting guideline criteria, end up undergoing parathyroidectomy, We know that. Certainly some of that's because of cost, because of risk. But a lot of this is with patients underestimating, or maybe more broadly, having uncertainty about the potential benefit with parathyroidectomy. We set out to personalize outcome prediction in primary hyperparathyroidism and to help identify which patients may benefit from surgery. And we started by looking at fracture prediction. How do we currently personalize this decision-making with patients? We look at things like bone density, right? We know about this. Patients with osteoporosis, we expect to have greater benefit. We published on this using the Trinetics database. And I just want to take this as an opportunity to tell you more about this data set because this is what we used for the entirety of our work. It's a national EHR-based data set, uses 132 million patients across the United States. We refined this to 90,000 patients with primary hyperparathyroidism. A quarter of them were treated surgically. And these are cumulative incidence curves of major osteoporotic fracture. The top curve is the non-surgical group, bottom curve is the parathyroidectomy group. And just looking at those with osteoporosis, you see this absolute risk reduction. You're seeing the separation of the curves. Patients with osteopenia, you're still seeing some separation. And then even those with neither, you're seeing some separation. So we look at bone density. That's what we currently have. And we ask the question, can FRAX identify, is there an off-the-shelf risk calculator for fracture that we can repurpose for our own interest to better risk stratify these patients? This FRAX calculator predicts 10-year probability of major osteoporotic fracture and hip fracture using 12 variables. Some of us may use it, but it's usually the medical endocrinologists who use this calculator. They plug in the patient's information and then determine the need for osteoporosis therapy. However, it was not specifically designed for nor well validated in PHPT. And interestingly, right after it was released for public use 2008, our own PHPT guidelines, the third international workshop said, well, sure, it would be great if we could somehow figure out how to use this in PHPT. Fourth international workshop asked the same question. No one figured it out. Fifth international workshop still asking this question. And of course, you know what I'm going to tell you next year is that we have shed some light on this using our Trinetics cohort. This time, 59,000 patients. For each patient, we plugged in all of their variables into the FRAX calculator and got these FRAX predictions and then compared those predictions to the actual observed values. We modeled the parathyroidectomy effect on fracture as a function of FRAX score. And I'll try to help you make sense of these graphs here. This is the hazard ratio for major osteoporotic fracture. And on the x-axis are the FRAX scores. And so anything less than 1 is indicating some benefit for parathyroidectomy. And you're seeing a more clear benefit over a certain threshold here, a pretty low threshold. And then looking at the other possible outcomes here, so hip score on hip outcome. And then on the bottom, these bottom two are all fracture outcomes. And looking at MOF score and hip score. And you're seeing there's different thresholds where above which we're seeing a much more clear benefit. I think the most interesting graph is graph D here, where basically for any hip score, the all fracture outcome, all of those patients were receiving benefit. So maybe there's a lot more patients who may benefit from parathyroidectomy than previously accepted. How do you remember all these thresholds? Don't have to worry about it. We've put this together as an app that you can access from your phone itself. I don't want to distract you with that just yet, but I'll tell you a little bit more about that in a second. So how do we move beyond FRAX? FRAX has some variables, the same variables we put into our model, they're in black, but we added additional variables that we thought were relevant and interesting for this specific disease process. We acknowledge that this is not randomized data, it's retrospective, and there's certainly non-random treatment, so we used some weighting to try to account for this. And we built these random survival forest models, their tree-based machine learning approach, to predict fracture and mortality as functions of time. We combined the fracture hazard and the mortality hazard to try to come up with a probability of fracture before death. I'll just blow through this here. You've seen this is how the cohort was constructed, same 90,000 patients from the Trinetics cohort. This is what we built our models based off of. I won't belabor this slide too much either, but just looking at the cohort characteristics, surgical, non-surgical groups, some key differences a little bit, and then after weighting, those differences minimized. And then we ask the question, in this data set, is there actually signal that we can model off of? Left hand is the MOF curves, right hand are the all fracture curves, non-surgical versus parathyroidectomy. And you see these curves do separate, small differences, but we're seeing that, and that's what we're modeling. We built these models, and we want to look at the predictive ability or the performance. And the MOF models are the ones I'm going to focus on for the rest of these slides, but the all fracture models performance are actually very, very similar. And so we look at this calibration, predicted risk versus observed risk, and we pick the t equals 5-year time point to start. Along this curve, that slope is very close to 1, the intercept is very close to 0. Those are the ideal numbers for ideal calibration. And then we look at what about other time points besides just 5 years? And these aren't deviating too far from the ideal calibration, so we're not unhappy with that. Looking at the receiver operating characteristic, again, now this is a 5-year landmark. The AUC for the overall model above 0.7, we're seeing then you separate it out by non-surgical and parathyroidectomy, also reasonable performance. And then picking a specific threshold, and this is the mathematical optimization, may not be the clinically appropriate threshold, but certainly for the mathematically optimized threshold, reasonable performance metrics here, specifically looking at balanced accuracy and sensitivity, in this case with a low positive class. These machine learning models, everyone always wonders, well, what's it really looking at? So here's a window under the hood here at feature importance. And just looking at all of these, but certainly the top 5 are all the same important fracture predictors that we already know about from other predictive models. This is what I'm most interested in, the individualized treatment effect of parathyroidectomy. And so this is taking each patient and then presenting with or without surgery, what would be their fracture risk. So this is a probability density curve. On the x-axis, anything less than 0 indicates fracture risk reduction with parathyroidectomy, which we're seeing here in 82% of the cohort. Here, this model is not finished and ready for prime time. We certainly haven't submitted it for publication. We're doing a little bit more fine-tuning and refinement, but we've already put this available, accessible on the web. I would be so grateful if anyone could give us some feedback. This is something long-term I would love if we all would be able to use if so desired. And so I would love to get some feedback as to what you would like to see differently if you actually wanted to use this in practice. Please share feedback with me. I would love to collaborate on external validation with folks. Thank you to my mentors, and again to the AAES for this award. This has really made a big difference in my professional growth and professional life. First, by having the preliminary data to get further grants, but then honestly, just the vote of confidence from my subspecialty society to say we believe in you. I think that's made the difference to get a number of intramural and extramural awards to pursue this work. Thank you all so much.
Thank you so much, Dr. Sant, for that fantastic presentation. Last but not least, I'd like to welcome Dr. Lina Hu-Bianco from the Beth Israel Deaconess Medical Center, as she's coming to the stage, if we can pull up her slides. And Dr. Hu-Bianco was the recipient of the THICA Award for 2024.
Hi, my name is Lina Hu-Bianco, and I'm an endocrine surgeon at Beth Israel Deaconess Medical Center and assistant professor at Harvard Medical School. I would like to thank the AAES and the THICA Association for the award that made this research possible, and I want to thank the program committee for the opportunity to present these results with you today. As this audience knows well, contemporary evidence supports the de-escalation of treatment for small, low-risk thyroid cancer to reduce perioperative and long-term morbidity. These data are reflected in the updates to the ATA and NCCN guidelines. Since the 2015 and 2016 updates, practice patterns have shifted, but adoption has been far from universal. This is a study using SEER data from 2000 to 2018, evaluating thyroid cancer management trends across 2 major guideline updates. The black line shows total thyroidectomy with RAI, the yellow line shows total thyroidectomy alone, and the blue line shows lobectomy. Over time, you can see an overall decrease in total thyroidectomy with RAI and a corresponding increase in lobectomy. However, by 2018, even for the smallest cancers under 1 centimeter, lobectomy rates remain low compared to total thyroidectomy. More importantly, we know that disparities exist in access to appropriate thyroid cancer care by race, ethnicity, and insurance status. We also know that guideline concordant care has been associated with better outcomes, both in thyroid cancer as well as other cancers and diseases. There's also evidence to suggest that improving guideline adherence can decrease practice variation and potentially help address some of these observed disparities. As such, there is a clear need to understand what drives variation in guideline adherence. So given the complexity and heterogeneity of health systems, we wanted to leverage both quantitative as well as qualitative research methods to more fully understand the potential modifiable patient, disease, and system-level characteristics that influence the receipt of guideline concordant care. Our first aim was to characterize these characteristics using a national cancer registry. We used the SEER-17 registry data, which captures about 26% of the US population. We included roughly 100,000 patients with differentiated thyroid cancer, with 46 diagnosed before 2016 and 58,000 after 2016. In the post-guideline cohort, most patients were 45 years or older, female, white, non-Hispanic, and married or partnered. We defined guideline concordance according to the 2015 ATA guideline and the 2016 NCCN guidelines. So ideal concordance was defined as a receipt of guideline recommended treatment based on the available features in SEER. Acceptable concordance included treatments that may be considered guideline concordant based on factors not captured in SEER, such as the presence of contralateral nodules, hypo or hyperthyroidism, family history, patient preference. And finally, discordance was defined as any treatment that is not recommended by the guidelines. Here is just a very brief summary of how we defined guideline concordance in our study. As an example, for patients with tumors 1 to 4 centimeters, lobectomy without radioactive iodine was considered ideally concordant, but total thyroidectomy was considered acceptably concordant in this instance. To orient you to this figure, the top panels are pre-2016 data. The bottom panels are post-2016 data. The left panel shows surgical concordance, and the right panel shows RAI concordance. Although there were minor differences between the ATA and NCCN guidelines, the results were very similar. And so in the interest of time, I will only present the ATA data here today. The first thing I want to highlight here is that ideal concordance did improve over time, from 45% to 53% for the extent of surgery and 71 to 77% for RAI therapy. And this improvement was largely driven by de-escalation of therapy for small localized thyroid cancers under 4 centimeter. However, we also observed an unintended consequence in the era of de-escalation. A small subset of patients with more advanced disease, so larger tumors and regional nodal metastases, were undertreated and received less guideline concordant care. This slide shows factors that are associated with ideal concordance with the ATA guidelines, green for greater odds of ideal concordance and red for lower odds. Just to summarize this busy slide, for surgery, older age, female sex, Black race, being married, living in the Northeast, and lower median household income were associated with lower odds of ideally concordant surgical care. For RAI, earlier year of diagnosis, female sex, Hispanic ethnicity, living in the Northeast, and lower median household income were associated with lower odds of ideally concordant care. As far as cancer and guideline characteristics, for surgery, histology other than papillary and tumor size between 1 and 4 centimeter were associated with lower odds of ideally concordant care. And for RAI, histology other than papillary, tumor size greater than 1 centimeter and having only 1 to 5 positive lymph nodes were associated with lower odds of ideally concordant care. Finally, when the ATA and NCCN guideline recommendation differed, there were lower odds of ideally concordant surgery and RAI care, highlighting the impact of conflicting guidelines at the point of care. Moving on to our aim 2, which was to characterize the provider and system level factors using quantitative interviews. We conducted 10 semi-structured interviews with endocrinologists, surgeons, including endocrine surgeons, otolaryngologists, and general surgeons from the academic and community practices. We asked about perceived barriers and facilitators of guideline implementation in their own clinical settings. We used the Cabana framework on barriers on physician adherence to practice guidelines and grouped the themes under 4 domains. So the first is physician-related factors, which includes the physician's knowledge and attitudes about guidelines. Participants in our study reported high familiarity and agreement with the guidelines themselves. However, they frequently cited limited knowledge and familiarity among non-specialists and community physicians as a major driver of variation in care. On the flip side, motivation to update practice in response to new guidelines and participation in multidisciplinary tumor board were cited as important facilitators of guideline concordant care. Here are some illustrative quotes. One physician referring to another surgeon said she was constantly butting heads with endocrinologists who wanted total thyroidectomy on a low-risk patient, trying to bring up these ATA guidelines, which they didn't want to follow. On the other hand, our endocrinologists were on board with changing their practice because they were much more aggressive about the management of small thyroid cancers, even in low-risk patients prior to 2016, 2017. The second domain is guideline-related factors, specifically characteristics of guidelines and the presence of contradictory recommendations. So participants highlighted weak evidence and ambiguous recommendations, particularly for intermediary cases, as important sources of uncertainty in decision-making. In this quote, one physician said, "Sometimes there is no evidence, or the evidence we have available is limited, so I'm having a little bit of a hard time accepting them." The third domain is system-level factors, including environmental and organizational constraints. So clinicians cited fragmented referral pathways, uncoordinated electronic health record workflows, diagnostic delays, and limited availability of specialized services in the community as key barriers. Again, the availability of multidisciplinary tumor board emerged as a consistent facilitator of guideline concordant care. Some quotes here. One physician said, "Our system is not closed, our system is wide open, and we're getting referrals from people out in solo private practice, and none of those physicians are necessarily all linked to the Epic medical record." And finally, the final domain is patient-related factors. So clinicians emphasize patient and cancer anxiety, health literacy, and language barriers, and personal and socioeconomic barriers to follow-up all substantially influence management decisions and pull the care away from strictly guideline-recommended pathways. One physician here said, "I will say that theory is different from reality, and patients get anxious knowing that they have cancer, even if it's extremely, extremely small, and they do nothing about it." So in summary, in the years since the 2015 and 2016 guideline updates, we do continue to see movement in the right direction, but that progress has been slow, and guideline concordant care is far from universal. Disparities in guideline concordant care persist by age, sex, race, ethnicity, and geography. And finally, persistent practice variation reflect interacting physician guideline system and patient-level barriers, highlighting that improving thyroid cancer care will require coordinated interventions across these levels. Building on these findings, our next step is expanding our interviews to primary care physicians to understand their role in thyroid cancer evaluation and referral, and identify specific knowledge gap, workflow issues, and system constraints from their perspective. We have interviewed about 7 PCPs so far, and we're still recruiting. Second, we're going to be interviewing patients to capture their experiences, preferences, and cancer-related anxiety, and the barriers they face in accessing and adhering to care. And finally, we'll use this data to develop a conceptual model of guideline implementation in thyroid cancer and perform intervention mapping. The goal of that is to identify concrete multi-level strategies that can be tested to improve equitable guideline concordant care. I'd like to thank my mentors, Jean Marie Gies, Ben James, Bruce Rodriguez, and Bruce Landon, and Susan Mofford Bruce, who are my mentors. So this work is additionally supported by a Massachusetts Center for Excellence and Excellence and Equity in Learning Health System grant, and they were my mentors for that. And I also like to thank the residents and fellows in our lab whose hard work on data collection, analysis, and interviews made this work possible.
Thank you, Dr. Hubianco, for that fantastic work. And I'd like you to just all join us in a brief round of applause for all of our 2024 Research Award recipients. We can't wait to see what you do next. So we have changed up the program a little bit this year, and it is my distinct honor and privilege to actually now announce the recipients of the 2026 Lo-GERFO and THICA Awards, which we usually did at the gala, but we've moved this forward so we can all appreciate their contributions. So the recipients should please come to the stage and accept a certificate, and then we'll take a group photo at the end. So I hope you would join me all in congratulating our first Lo-GERFO Award recipient. This award is going to go to Dr. Ala Sada from the University of Pittsburgh. If Dr. Sada would come to the Next, I would like to announce the recipient of our second Lo-GERFO Award is Dr. Jordan Bruckhuss from the University of Nebraska Medical Center. If you'll join us here on the stage.
Thank you so much. Congrats. Thank you.
Smile right here. Hold that.
And then lastly, I would like to announce our 2026 THICA Award, and this award goes to Ali Anvari from the Massachusetts General Brigham. Thank you all, and we'll have a brief round of applause for our 2026 Research Award winners. And next, we'll have some remarks from our recorder, Dr. Rachel Kells.
Oof, it's very bright up here. Good morning, everybody. I'm privileged to serve as your recorder, and in that capacity, I also have the distinct pleasure of reminding everybody of our ethical obligations to research integrity. So today, I decided instead of highlighting some of the problems that we've had over the past year, that I would take the opportunity to remind everybody of ways to be successful in navigating the submission process and becoming a podium presenter. So it starts before you submit your abstract. If everybody would kindly pay attention to the detailed instructions that are on the submission page, that would make 95% of the problems go away. You need to have an AAES sponsor if you're not a member yourself as a senior author or a first author. There are also requirements for the senior author to attest to their participation and oversight of the scholarly work all the way through to the publication in January. That does require that you submit your manuscript in a timely fashion. Please do not make me chase you down. I do love talking to everybody, and I would be happy to take your contact information if you'd like a call. But otherwise, for the manuscript presentations, it would be much better if you could submit them on time. That means they have to be formatted for surgery, so there are instructions for authors on the surgery website, and if you're not familiar with them, send me an email and I will send you a link. They will detail how it has to be submitted, because when you submit, if you're submitting at 11:59 on the deadline and it's not formatted properly, it will get sent back to you for reformatting. Once you navigate that process, you want to make sure that you're using the AAES manuscript if you have been accepted for a presentation at our annual meeting. If you're submitting an endocrine topic or an endocrine surgical paper that is unrelated to the meeting, you should just go ahead and submit through the usual platform, but otherwise use the AAES manuscript designation, so that will get your paper properly routed and we won't have any delays. Once your paper starts to go through the process, if you're having problems with deadlines for revisions, please contact me in advance, and that way we can make sure we come up with a mutually agreeable solution to the problem. If you're going to have a problem meeting the original deadline, also contact me prior to the deadline so that we can adjudicate that problem as well. The final thing I want to mention is there is an AI tool that is used at most publishing houses, including Elsevier, which is the surgery publisher. And if your manuscript has too much overlap with a prior publication that could even be your own, then it is going to be flagged and they will not consider it for publication. So the expectation is that the science that you're submitting and the content is new. It's not an update of 6 patients from a prior study or any dramatically overlapped stuff, because you can self-plagiarize. So keep in mind, these are not our rules. These are sort of the general rules of scientific integrity. And if you have flagged the AI software, we try to work through it, but it's not always possible. So please make sure the content that you're submitting is new. Finally, when your work is ready to go through the process, we really look forward to your work. We look forward to reading your report. We're going to make some suggestions next year to make your scientific reporting even more robust. Our reviewers, we're very grateful for all of your contributions, and if you can't review, I understand that as well. Just send some suggestions of who we should tap in lieu of your ability to review for us. So please bring your best ethics forward. We have many ethicists in the audience. If you'd like to be connected to one of them, we're happy to offer their services, and I hope you enjoy the rest of the meeting. Thank you.